Well, this is fabulous that we are so many people here. So a warm welcome for this webinar that will make us understanding FSHD, disease mechanism, genetic diagnosis, and practical implications for patients and families. My name is Caroline Elmstedt, and I'm from Sweden, Neuroförbundet in Sweden, and I'm also the Vice President of FSHD Europe. So this webinar is one of our strategic pillars, that is patient advocacy and education. So some house rules. This meeting, as you can see, will be recording, so you can choose to have your camera on or off. And we will also put the recording on the FSHD Europe's website. So please mute your microphones. And if you have a question during the presentation, raise your hands and I will give you, or you can also write your question in the chat. So now the most important one here is Professor Emiliano Giardina. He's a PhD, Associate Professor of Medical Genetics in the University of Rome. He also directs several laboratories in Santa Lucia. And now he's also a forensic genetic laboratory. So a warm welcome to Emiliano, and you will get your presentation.
Thank you very much, Caroline. Good afternoon, everyone. Thank you so much for being here today. I like also to thank the organizers for having organized such important meeting. Thank you for the kind presentation. So my name is Emiliano Giardina. I'm the director of different laboratories in Italy, involving both forensic and medical genetics. But above all, I have the privilege of working with families affected by facioscapulohumeral dystrophy every day. Today, I would like to talk with you about something really important for us and for you, but also a little bit technical, so the genetic testing of facioscapulohumeral dystrophy. So what is my goal today? It's quite simple. It's to explain these things in a clear way, in a human way, so that you can leave this room feeling more comfortable, more confident about the genetic testing, and better prepared for your choices. I would like also to say you that this is a very live session, very informal, so please feel free to interrupt me at any time, whenever you want. So before starting, I like to give you just a brief sum up about what I'm going to do today. So I would like to give you just a brief introduction on the genetics of facioscapulohumeral dystrophy, such as the distinction between the two forms, the form 1 and the form 2, the role of the genes involved in the pathogenesis of the disease. I would like also to explain to you in a simple way the difference between genetics and epigenetics that are both involved in this disease. I would like also to give you some important information, practical information about the genetic testing at prenatal stage, postnatal stage, and most importantly, I want to outline the importance of the genetic counseling. That is, in my opinion, is one of the most important things of this lecture. So let's start from the very beginning. So the FSHD stands for facioscapulohumeral dystrophy. It is a genetic condition causing weakness and wasting of muscles, especially in the face, shoulders, and upper arms. It usually starts in adolescence or early adulthood and gets slowly worse over the time. In most people, the first sign appears during the adolescence, and the first muscles involved are in the face. Some people may have very mild symptoms, while others may experience more significant weakness. And we will talk about these differences and this variability in the expression of the disease in my talk. So the facioscapulohumeral dystrophy is not the only muscle dystrophies we have. It belongs to a larger family of diseases that we call altogether muscle dystrophies. In this slide, you can see that every different disease can have different muscles affected in different ways. And so why this is so important for you? Because each muscle dystrophy has a different cause, and also different treatments. So that's why a precise genetic diagnosis matters so much. And here is one of the most important things I want you to take home today. So facioscapulohumeral dystrophy, your disease, does not look the same in every person. Some people may have mild symptoms and can live a normal life with little or no disability. Others, unfortunately, may develop more serious muscle weakness and need support with daily activities. The disease can start at different stages, and the muscle affected can vary. So even within the same family, we have this heterogeneity in terms of specificity of the disease. And so this is really important. And this is not a coincidence. There are a lot of biological reasons for it. Some of them are really complicated, others are more simple to be explained, and we will talk about them. But the practical message that I want to deliver now is simple. So if a relative of yours has the facioscapulohumeral dystrophy, this does not automatically tell you what your own experience will be. So each person's story is unique. So it is very important. Every patient is a story alone. So facioscapulohumeral dystrophy follows an autosomal dominant pedigree pattern. So autosomal means that the gene in question is located on one of the non-sex chromosomes. So this disease is not a gender dependent. Dominant means that a single copy of the mutated gene from one parent is enough to cause the disorders. We know that there are more than 1,500 dominant diseases that have been described so far in humans. So this is not unusual. About 1% of live-born infants carry a gene for autosomal dominant diseases. So I would like also to remind what in practical terms autosomal dominant means. When a person who carries the facioscapulohumeral dystrophy genetic changes, the mutation, when this patient as a child, they pass on one of the two gene copies. It can be the normal copy, or it can be the mutated one. Each one has exactly the same chance of being passed on, 50-50. So for every pregnancy, there's the 50% probability that the child will inherit the mutation or the normal allele. I have prepared this slide just to try to help you to understand something very important. This 50% is for each pregnancy, independently. It does not mean that if you have two children, one will be affected and the other not. It is exactly like flipping a coin every time. Both children could inherit the change or neither of them. So this is why the family planning, when designed, deserves a careful conversation with a genetic specialist. So what we call genetic counseling. This is extremely important. The genetic counseling gives you the time and the space to understand exactly what the disease means for you and for your family. And you have to pretend the genetic counseling. And so now I want to introduce a concept that is complicated also for our students. And so it is the reduced penetrance. The facioscapulohumeral dystrophy is a genetic condition but not everyone who has the genetic change will show symptoms. This is called reduced penetrance. Penetrance in practical terms in genetics simply means how often does a genetic change actually lead to the disease. When the penetrance is 100%, it means that everyone carrying the genetic change will develop the disease. When the penetrance is reduced, and it is the case, some carriers will develop symptoms and others will not. So, facioscapular humeral dystrophy has a reduced penetrance. This also means that some people in the same family may carry the genetic change but never develop muscle weakness. I have prepared this picture just to help you to picture what reduced penetrance means in real life. The person on the left does not carry the genetic cases of the disease. It is completely normal and it is well, so we have nothing to add there. But the other two, on the contrary, both carry exactly the same genetic variation, the middle one and right one. But there are some differences. Despite they carry exactly the same genetic variation, one is not affected and we call non-penetrant. One is affected. So this is one of the most challenging aspects in diagnosing and treating facioscapular humeral dystrophy. So why does this happen? To be honest, we don't know yet all reasons. Now we have a clear picture of the disease, but there are also some pieces of information that are missing. And because what we know is that other genetic factors, such as lifestyle or even chance, can play a role. So closely related to reduced penetrance is another concept called variable expressivity. So in facioscapular humeral dystrophy, people with the same genetic change can have very different symptoms. Probably you have this experience on your own. Some may have mild weakness in few muscles, while others may have more severe symptoms and need support to work or to do daily activities. This phenomenon is called variable expressivity, and it means that the condition does not affect everyone in the same way, even in the same family. We and my groups have carried out a lot of studies about that, and now we have a clearer picture about what can be the explanation for that. But the picture is not clear at 100%. So just to help you to understand the difference between variable expressivity and reduced penetrance, if reduced penetrance answers the question, will the disease appear or not, black or white system, variable expressivity answers a different question. When the disease does appear, how severely will it show? So this is the difference. I have prepared for you also this slide just to help you to visualize what variable expressivity means. So a genetic test tells us what is happening at the level of the DNA, but the clinical pictures, only the clinical picture tell us how that genetic change is showing in this particular person, in this particular moment of their life. So both pieces of information are essential. And so this is the reason why we have included this piece of information in the revision of the international guidelines for the genetic testing. So I want to show you a family that we have studied in my laboratories, showing in concrete way what we have just been discussing. So the black symbols represent family members who have developed the facioscapular humeral dystrophy. This is the same, a very large family. But if we look at the third generation, we can see that these two daughters have a completely different stories. One is very, very mild affected, other very severely affected, but they have exactly the same genetic variation. So this is the practical demonstration about what is the penetrance and variable expressivity side by side in a single family. And it is why when we counsel families about facioscapular humeral dystrophy, we are always very careful with predictions. So we can talk about probabilities, but we cannot predict 100% exactly how the disease will be in a specific person. So this is a very important take-home message. So in this slide, you can see the two concepts, reduced penetrance and variable expressivity. So same genetic change, very different stories. You have your own stories. So this is just a remind that the severity of FSHD follows a spectrum. But it is important to remind that even if a relative has a particular form of facioscapulohumeral dystrophy, particularly severe, your own experience might be different. So your story is your own. So this is really important for us. It is also one of the most challenging steps for us as geneticists, that we have to develop genetic tests. We have to predict how the disease will be, because the patients are not so interested in understanding exactly the pathogenetic mechanism of the disease. They ask us how the disease will be in me and my family. And so we cannot do that 100% with 100% of precision. So now let's go a little bit deeper into the genetics. Today, we classically distinguish between facioscapulohumeral dystrophy type 1 and type 2. And this discrimination is based on the underlying genetic mechanism. Both types share exactly the same phenotypes, but are caused exactly by the same inappropriate expression of the gene called DAX4 in skeletal muscle. However, the mechanism underlying this inappropriate expression of the gene are different. But for you as a patient, this distinction is not so relevant. But for us as clinician researchers, it is crucial to proper diagnosis, counseling, and also for being ready for the clinical trial. The first type is the most predominant, more than 90% of people, and 5%, the remaining 5% is type 1. We can have also some mixed version with type 1 and plus type 2. So in these first slides, you have understood that the genetic mechanism underlying facioscapulohumeral dystrophy are so intricate that one could easily write an entire genetic textbook dedicated to a single disease. So we have the interplay between repetitive elements, epigenetics, haplotype, and gene regulation makes the facioscapulohumeral dystrophy a good model for understanding the gene expression control and chromatin biology. So to understand FSG, we have to talk about the main gene, the DAX4. DAX4 is the main gene in healthy people. DAX4 is normally active only at the very early beginning of the life, in the first day after fertilization, when an embryo is just a small group of cells. And DAX4 helps to turn on the first group of genes needed to start the development. Later in life, especially in muscle and other body tissues, the gene needs to be turned off and stay inactive. This is important because DAX4 is not supposed to be active in adult tissues. What happened in patients? Because DAX4 is a powerful gene, what happened is that sometimes in our patient, the normal control of the DAX4 gene doesn't work properly, because some genetic variation, different explanation that we will have probably the chance to talk later, this control doesn't work. And the gene gets turned back on in muscle cells, where it should stay silent. This causes a problem, because DAX4 gene is a powerful gene, and also some very small amount of the activation of the gene in muscle cells can switch on a whole chain of other genes that should not be active. So the result is a sort of biological chaos inside the muscle cells: stress, inflammation, death of muscle cells. And over the time, this damage accumulates and the muscle becomes weaker. So in simple word, the FSG is a strange disease where the disease appears when a gene is active and not the opposite, as the large majority of disease are in genetics. And so I have prepared this image to make you this point really clear. On one side, we see what happens in a healthy person. DAX4 is silenced, the lock works, the muscle cells are protected, and this individual is completely healthy. On the other side, we see what happens in a patient with facioscapular humeral dystrophy. DAX4 is expressed, the lock has failed. The DAX4 is talking inside the muscle cells, and this leads over the time the muscle damage and weakness. So now we have to introduce another key concept. The methylation is important also for the diagnosis. That's the reason why I'm going to talk to you some words about that. This word can sound a little bit technical, but the idea is quite simple. So the methylation is a chemical switch that helps keep some genes turned off when they are supposed to not be active. In healthy muscle cells, this switch keeps the DAX4 gene turned off, and this is a good thing for humans. But when methylation is reduced, and we call hypomethylation, probably most of you are hypomethylated, this switch doesn't work properly, and the DAX4 can turn on, causing the damage to the muscle. So I have prepared this simple representation of what methylation is. So we have to think to methylation like the locks on a door. If the door has a strong lock in the left, it stays firmly closed. Whatever is inside cannot come out. And so and this is exactly what happens in healthy muscle cells. When the methylation is reduced, the lock is broken. The door can be opened, and therefore, what is inside can come out. The DAX4 can come out and cause damage. So this is the reason why we are using the methylation analysis in our lab, because methylation can tell us how many locks are still working on your door, and this gives us very useful information for the diagnosis. So it helps us it adds a different piece of information respect to the genetic variation alone. It also gives us a clear picture about how you are exactly in the moment we have you in front of us. And see, again, using the same slide as before, when the region is methylated, the light is switched off. When there's the hypomethylation, the light is switched on and the DAX4 can be present. And so now let's look at what actually happens at the level of the DNA. We have talked about families, we have talked about reduced penetrance, variable expressivity, but now we have to talk about the level of the DNA. In a person with without FSHD, there are many copies of a specific region of the DNA called D4-zeta4 on the chromosome 4. And this number of repetition can range between 11 to 100, and that's good. This number of repetition is enough to keep the DAX4 gene turned off. So it doesn't make any protein in a muscle cell. It doesn't make any problems, probably, in muscle cells. But what happens in the patients affected by the Form 1? The number of repetition is too small, ranging from 1 to 10. This reduced number of repetition allows to the genes, the DAX4 gene, to be present, to be active, and produce the harmful protein in your muscle cells. So in both types of facioscapular humeral dystrophy, the same problem happens. So the DAX4 gene that should be not active is active, and therefore this can cause the damage. But the difference between the type 1 and the type 2 is the cause of this inappropriate activation of the gene. So in In facioscapulohumeral dystrophy type 1, the main cause is the reduced number of repetition. In type 2, we have a borderline range of repetition ranging from 11 to 20, let me say 8 to 20, but there are also some mutations in other genes. These genes help the silencing controlling of the gene to be active. But if something is wrong in this gene, if we have some mutation in this gene that we call the silencer, probably the silencing controlling doesn't work, and so the gene can be present. And we have a list of 3 or 4 main genes that are responsible for this variation. And so this image summarizes exactly in one picture what we have just described. On the top, you can see what an healthy chromosome 4 looks like with a long row or repetitive element, and the genes that are perfect, the gene controlling the area, remaining like a cover over the gene is perfect. But in the patient's one, the number of repetitions is too small, and therefore the DAX4 can be present. In the type 2, we have a borderline number from 11 to 20, but we have also some mutation in the genes helping our DNA control to remain inactive. So in recent years, our understanding of facioscapulohumeral dystrophy has changed in an important way. For a long time, we have treated the Form 1 and the Form 2 as 2 completely different diseases. They were classified separately, but now we know that they are not so different between the Form 1 and the Form 2. So, and what is important to understand is that sometimes we can have also some patients having the Form 1 plus the Form 2. And that's the reason why we have included some specific assay, some specific genetic test in the recent revision of the international guidelines, some specific tests enabling us to understand if we have in presence of a patient classically intended as 1, but also plus some mutations in other genes that they can explain us the heterogeneity that we have talked about before. So before we move on, now we can talk about the genetic testing. Before we move on, I want to remind you something that, in my opinion, is really important. Research on FSHD never stops. So every single day in laboratories all over the world, scientists, researchers, clinicians are working on this disease. We are improving the diagnostic test. We have improved the diagnostic test. We are discovering new genes involved. We have discovered new genes. We are testing new molecules in cells, in animal models, and also we are trying them in every clinical trials. So why I'm stressing this point so much. So when you leave this room, please carry this information with you. Research is moving. The patients' organization like FSHD Europe are a fundamental part of this movement. So we are a community of people working to fight the facioscapulohumeral dystrophy. That's really important. The importance of the patient's organization cannot be overestimated. So now I would like to just give you some details about the revision of the diagnostic guidelines. Sometimes, in some cases, this could appear a little bit too technical, but so I don't want to go into all details, but I want you to know that there is now a clear picture of the disease, and the aim of these new guidelines is quite simple: to make sure that no patient is left without a proper diagnosis. So this is real. Or even the atypical cases, the strange cases that were classically difficult to be classified, now can be identified. So this is the reason why we have revised the diagnostic guidelines, and for you as patients and families, that means that today the chance of getting a clear answer from the genetics is much higher than ever before. So this is important. So now we have revised the diagnostic guidelines, and we started from the clinical picture. So we have revised the clinical guidelines, recently revised by the community of experts. This is important. It was not a revision by Emiliano Giardina, Richard Lemers, or Nicole Vernon, so all the friends working on the disease, but the entire scientific community working on facioscapulohumeral dystrophy. We are all together fighting this disease. This is the very important message to deliver. Now we want to include the clinical aspect, but also the genetic and epigenetic aspects. The genetic is the number of repetition, the epigenetic is the methylation. So no patients can be left behind. So also the typical cases can be now analyzed. And so what about the diagnostic guideline? We start with the clinical evaluation. So the guidelines now recommend interpreting your results, including the context of the haplotype, the methylation status, and the clinical features. So it's important to emphasize this key principle underpinning the current diagnostic strategy. The diagnostic workflow now begins with the clinical evaluation. Rather than starting with the genetic testing alone, the updated approach recognizes that the clinical phenotype is really important. If the first genetic analysis we have, the first level, is able to explain the phenotype, we call that we have a strong genotype-phenotype correlation. There's nothing to add. It's sufficient, and you can have your specific diagnosis. But when the genotype we have is not enough to explain completely your phenotype, your phenotype is more complicated than the average one, we have to add methylation analysis, the sequence analysis of modifier genes, or other piece of information helping us to give you a clear answer. So we have three factors in your diagnostic report, and we are also working hard with Nicole, that I want to thank for all her efforts in this for us as geneticists. We are working hard on a standardized diagnostic report to be used all over the world. This is important. So it is important also for the clinical trial. So the first factor we have to look at is the repeat number. Healthy, huge number of repetition, FSHD1 from 1 to 8, and borderline from 11 to 20. And so after that, we have to look at the methylation. So if the methylation is normal, something is strange. In the large majority of people affected by facioscapulohumeral dystrophy, we have the low methylation. The low methylation can also give us some advice if some of the other genes can be mutated, and so can suggest us to move forward to a third level of analysis. The third level is the analysis of the modifier genes. Okay, now I want to talk to you about the genetic testing in a practical life. Why and when and why do we perform genetic testing for facioscapulohumeral dystrophy? We can have the genetic testing at the pre-implantation stage, at prenatal stage, after birth, so as a confirmation of symptoms, and also as in your family or as a carrier testing. Each of these situations poses different technical, ethical, counseling challenges, and must be carefully addressed with tailored communication and support, and we call genetic counseling. This is extremely important. Every genetic disease, every genetic patient needs a genetic counseling. So, okay. So the importance of genetic counseling cannot be overestimated. It's a special kind of medical conversation and help you to understand a genetic condition like FSD works to know the risk for themselves and your family, ask questions about diagnosis, testing, and further children, make informed decisions about health care and family planning, receive support during emotional specific period of time, take the time you need to process the information, reflect and decide what feels right for them. This is really important. So we always say genetic counseling is not just an information exchange, it is already care. So we need to have a genetic counseling for you, for your family members. So, and this is why I want to repeat one again that the most important message of this call, there is no rush. Genetic counselors give you the space and the time to understand, to understand, to ask questions, to make choices at your own pace. If you ever feel that someone is pushing you to take a genetic test before you are ready, please remember that it is not exactly not how this process should work. The right test at the right time with the right support. This is the goal of the genetic counseling. And also to understand if you need a genetic test, because sometimes the genetic counseling is also important to avoid unnecessary genetic testing. Because the genetic testing for facioscapulohumeral dystrophy is really expensive. And so we have to save money to be sure that we have the money to diagnose all people who really need the genetic test. So now let's talk about why testing the family is so important. The diagnosis of the genetic condition should be always performed on an entire family, not a single individual. So the family testing is not just a curiosity. So it can have very real practical consequences for the health, for the choices, and for planning of every family members. For we have to look at the entire family. This is really important. And because we can confirm the diagnosis in the person with symptoms, we now understand exactly the expression of the disease running in the family. We can reveal silent carriers. We can also understand more clearly the genetic results, and we can also support the genetic counseling and future planning. So this is a very, very important issue to consider. But family testing is necessary because the disease can show up in many different ways, mild or severe in different family members. Some people carry the gene but never get symptoms, reduced penetrance. Some genetic variation can affect each people differently, what we have called variable specificity. So if you want to receive a good response, we have to analyze your entire family. So now let me introduce you to technical terms that you may have heard from your doctor, the direct testing and indirect testing. In simple word, in direct testing, we can see and test the genetic variation causing the disease. For example, the number of repetition of the mutation in the genes. In indirect testing, we cannot see the exact mutation, but we can follow the chromosome carrying the problem, the cause of your problem. And we can use some genetic marker like fingerprinting so to do that. Now let's talk about the pre-implantation genetic testing. It performed before implantation, during assisted reproduction, typically on embryos created by in vitro fertilization. It allows the identification of embryos that do not carry the pathogenic genetic signature. So it is a technique that helps couples at risk of passing the facioscapulohumeral dystrophy to have children free from the disease. It's a medical technique using in vitro fertilization to have children completely free from the disease, to identify embryos that do not carry the disease before pregnancy begins. And so that means that only embryos without the genetic mutations are selected or identified and transferred to the uterus, giving the couple the chance to have a completely healthy child, completely healthy for what concerns the facioscapular humeral dystrophy. It's impossible today to have 100% of sure to have an healthy baby. So the pre-implantation genetic testing starts with a genetic consultation. The first conversation is a moment of mutual understanding. It is not yet a decision. It's a moment to learn, to ask questions, and to start thinking about if pre-implantation genetic testing can be okay or not for you. And also, it is important for us because not all cases are eligible for the pre-implantation genetic testing. And so we have to understand exactly if your case is in your case it's possible to perform the pre-implantation genetic testing. After that, the second step is what we call the setup. This is a very technical phase, but it's crucial. The laboratory needs to design a personalized test just for you and for your family. To do that, we usually take blood samples from the couples, and we have to understand exactly we have to select the perfect strategy to follow the disease in your family and also in your embryos. After that, we have the third step, that it is the in vitro fertilization cycle in itself. And so the embryos are grown in the lab for 5-6 days. After that, we can take some cells from the embryos and we have to analyze them. After that, we analyze the embryos, and so we can identify the embryos not carrier for the mutation, and after that, we transfer the healthy embryos in the uterus. So what about the prenatal test? The prenatal test is during pregnancy, not before, like the pre-implantation, but during pregnancy, to find out before birth if the baby has inherited the facioscapular humeral dystrophy mutation. So it is usually performed through CVS or amniocentesis, and the test is only possible when we already know the exact genetic change or mutation in your family. So this is really important for us. So this is fundamental. We need time to perform a prenatal genetic test, and so you have to give us this time. And therefore, when we have to consider the prenatal diagnosis, when the facioscapular humeral dystrophy is really severe, and when it is early onset, or when one parent has the disease and wants to avoid passing it on. Before testing, we have also always the genetic counseling. Every genetic test needs to be performed during a genetic counseling. The genetic counseling is important to understand what is the best choice for you. So the impractical question is important. So it is possible to do the genetic test, the prenatal genetic test. Many people ask us, is it possible? Yes, but it's not simple. In some families, especially when the genetic picture is more complicated, such as in borderline cases or in type 1 plus type 2, the lab needs to prepare special tests in advance. That's why this step is so important. You should talk to a genetic specialist before getting pregnant. This is why I cannot stress enough. If facioscapular humeral dystrophy is in your family and you are planning a pregnancy, please talk to a genetic specialist before getting pregnant. In this case, you can give us the right time to give you the best possible treatment. So in this slide, I want to just summarize that planning ahead really makes a difference. This is a very important take-home message. Planning ahead really makes the difference because when a couple comes to us before pregnancy, we have the time to study the family's DNA, to plan the right test, to develop the right test. But if you come late, we have to race against the clock, and it is not good. What about the genetic analysis after the birth? After a clinical suspicion, to confirm a clinical suspicion of FSHD, to have a clear confirmation that you are a patient affected by facioscapular humeral dystrophy, and so we can have the type 1, the type 2, and also the genetic counseling can help us to give you the right response. And also, this is important to give you an accurate diagnosis, to plan the right care and follow up, to give to your doctor the right response, and also the genetic test will be performed only after a genetic counseling. So I'm going to conclude this talk with summarizing you some take-home messages. Some same genetic changes can give you different story. Your story is your own. Facioscapular humeral dystrophy can look very different in different people. And so this is important, even in the same family. The second point is a clear diagnosis is now possible. And so we can combine clinical evaluation, repeat sizing, methylation, and modern techniques into one structural pathway. So we are working together. We have a network of experts. We are receiving information from England, from Netherlands, from Austria. And so it is important that we are working together. So you can have access to all these kind of information because we are working as a network, and FSHD Europe is working really hard to give you exactly the best possible option. The third message is that genetic testing is not one test. It can answer a different question at a different stage of life. And so if you have facioscapular humeral dystrophy in your family, you have to consult a genetic consultant as soon as possible. There's no rush, but there's real value in starting early. This is the full message I want to give you. The genetic counseling is care, just not information. Is care, is already care. And knowing the family picture helps the whole family. So this is important. That's the reason why we can testing relatives is so important for us. And also my last message, but probably one of the most important, the research never stops, and you are part of it. Every single day, FSG research move forwards. Better diagnostic tests, methylation tests, new molecules, new clinical trials, and patient organization like FSD Europe is at the center of this moment. You are not alone, so we are all together with you to try to fight this disease. Finally, I want to spend a moment thanking the people who make this work possible. So the patients at first, the families, the patient organization, and without you, so we cannot have access to your sample, we cannot study the disease, we cannot have this kind of good results. I want to also to thank all my research group that are really active on this field, the Gruppo Clinico Italiano per lo studio della distrofia fascioscapulomerale, and all of you for your attention. And so if you want to get in touch with me directly, my email is on this slide, so you can write me. So my door, my inbox, my email are always open for you. Thank you for your attention.
Thank you so much, Emiliano. So do we have any questions? It was a lot of information, so.
Yeah. So we know that these are very complicated diseases. We can write an entire textbook of genetics, only describing the genetic underlying this disease. So it is difficult. This is the reason why the genetic counseling is important. I know that I have repeated that so many times, but in my experience, it happens that some patients can come out to our attention without a genetic counseling. And in some cases, it makes a difference.
Yeah.
Thank you so much, Emiliano. That was a very nice presentation with very clear explanations. I think the question that we receive quite often is, where can I find a genetic center in my country, or where can I go? Can you explain a bit about that?
Yeah. It is important to outline that the work we have done together with you, with Nicole, with Richard, and all the other friends is to create a network, a reference network for the genetic diagnosis. If they look to our national, international guidelines, we have listed exactly the number of centers that are able to perform the genetic test. Also on the website of FSHD Europe, they can find all this information. But above all, they can have access to our email, the email of all other geneticists working on the field. And so it is not a problem to reach the genetic experts, enabling giving them the right response. So but what is important to outline is that genetic test can take some weeks or in some cases months. So you have to be patient with us because the disease is really complicated. The genetic mechanism underlying the disease is really difficult to explain, and so we need some time to give you the right answer. So that's the reason why, if you are planning a pregnancy or something like that, you have to give us the right time to give you the best possible response. But now we are working to standardize the genetic approach to the patients. We are working really hard, and also with we are working on the revised diagnostic report to make every patient with the same genetic diagnostic report. It will be a great success.
Thank you. We have a question here in the chat. Is it useful to retest family members because of the findings are now different?
Yes, it is one of the most frequent question posed by patients. So it depends on the results. It depends on the age of the test. So, for example, if a patient has been tested 10 or 15 years ago, it depends on the test results. If the test was inconclusive, for example, or borderline, probably I can recommend to repeat the test, because now we have an improved version of our test. So it is important. One another issue to consider is that the answer is depends on the result. Because if you have a clear picture of your disease, if you have an exact number of repetition, there's no need to repeat the test. But if you have a result that was inconclusive, probably I strongly recommend to repeat the test. There's another issue to consider, that sometimes if you want to understand exactly some specific family member, we have also to repeat in the same lab the other family members to have comparable results among the different family members.
And here's another one. When you have FSHD, but family members, parents not, is preparation still possible and or useful?
It's a very complicated question. It is important to outline that. So we recommend to perform the test when the symptoms are present, even because we can have the silent carriers, so people with the genetic mutations but not expressing the disease. So it depends on the case, and only the genetic counseling can answer this question, because it depends, for example, if these members are planning a pregnancy. So in this case, it is strongly recommend to understand if they have inherited or not the genetic mutations. But it is important to outline that in asymptomatic people, international recommendation strongly stress the importance to have the test only when it is needed. And also, it is also important to make a distinction between adult asymptomatic patients with child or children or baby asymptomatic patient, because what is important, the international recommendation is to not test asymptomatic minors. So this is important. So if they are asymptomatic, they have to be the right to choose what is best for them, and therefore they have to know if they need to be in the position to understand what is best for them. They have the right to know and the right to not to know, and so this is important. So for adult people, it is only a matter of the person. In minors, it is a matter of the parents. But my stronger recommendation is to postpone the decision when they can understand what is best for them.
Are there therapies to slow down the progression of the disease?
Okay, so I'm a geneticist, so I'm not involved in the clinical care, but obviously all this therapy can have a role in trying to stop the disease, to stop the worsening, to slow the worsening. And so my strong suggestion is to follow the recommendation of their clinicians, because now we understand the disease quite well, better than before, and so we have some important options, and they have to follow with optimism this recommendation.
Is it possible to do genetic testing in other EU country if your own country doesn't have a center?
Okay, this is a very hard question to answer, as it depends. So it is also always possible to do that, but what is important to understand is that the cost of the test is really high, and therefore in some cases we can have the test reimbursed by our national healthcare system, but in other cases not. So this is the reason why we are trying to standardize the clinical, the diagnostic report. We are trying to standardize the genetic analyses that are necessary to be tested in every patient, because we want to get an agreement about that. We know that this agreement is not present at the moment, and so I can say that in some cases we are offering the genetic test also for patients in other countries where this test is not possible or is not available. But I want also to add that there are some centers in many countries, so it's quite difficult that in some specific country it's not there is not a center performing this kind of test. I want also to thank the Italian Association of Fascioscapulohumeral dystrophy patients, because sometimes they give us some money also to test people from other countries for free. So this is important.
We have another question: how physical effort connects with the DAX4?
Okay, so it is impossible to answer. We don't know. We know that physical exercise at low level can improve the symptoms. Okay, but we have not to stress too much the muscles. But what is the correlation between the exercise and the expression of the gene is really difficult. There's a reason for that, because it is a very powerful gene. Only a single copy of this gene is able to produce the chain of problems that I explained in my talk. But we are not able to detect this single copy. So it is impossible for us to test directly the expression of the gene in your muscle cells.
Well, thank you very much. Do we have a
Thank
last
you
question?
for your attention.
Or we have, now it's time's up actually. So thank you very much, Emiliano, and to all of you as well. The recording will be on our website afterwards if you want to look at it again. And as Emiliano said, you can always email him. So thank you very much and good night.
Thank you. Thank you very much for you all. Bye-bye.
Thank you.
Bye-bye.
Bye, Ria.
Thank you.
Bye.
Bye.
Thank you.
Thank you. Bye bye.